I really appreciate Bonnie inviting me to your class. Any opportunity I get to educate, I think it's important. As you well know, we have a heroin epidemic on our hands in Northern Kentucky. I have been in the emergency room for 21 years, and I will tell you we have not seen anything like this epidemic that we have going on right now in our community. We've seen drugs come and go, LSD, cocaine, all that, but it's not been, killing our youth as much as this heroin epidemic has. So back in 2012, I got a call from Dr. Engel, which is one of our St. Elizabeth physicians, and he said, "Michelle, I think we have a heroin epidemic, and I really could use your help." And I said, "Well, what do you need me to do?" He goes, "Can you get me some data on what you're seeing in the emergency room?" And I said, "Well, let me see. We just went to electronic medical record the year before, so I was really excited about that because I never really had a chance then to dive deep into the data and figure out what was going on." So it was pretty alarming to me when I started looking at the data. I actually went back and looked at data retrospectively from 11 and then moving forward. So I'm going to share with you a little bit about what I've learned. I'm not the perfect nurse, I'm going to warn you right now. I've had my biases. When methadone first came out, I was like, what the heck are we doing? We're substituting one drug for another. Yes, I was one of those who said that out loud. Not proud of that because once you start learning and educating yourself, just like I didn't have education when I was in nursing school. I think we got this much on alcoholism and that's it. I was very eye-opening to me. I had to look back at myself too and think, what was I doing? Because it truly is a disease with addiction. I think it made me understand things differently as a healthcare professional, and I've made it my mission to educate other healthcare professionals and physicians and community and whoever I can get my hands on what I've learned, because I really think it's important. I think we all have our biases and our stigmas with addiction, but I think once you start educating yourselves on that, it really does make a difference. They canceled my radio show interview today till tomorrow, but I've been on the Eddie and Tracy show for 700. If anybody knows them, they can be a tough crowd. They're pretty opinionated, and they kind of say what they want. But I've been very blessed to be part of their show for 3 times and then a 4th tomorrow, because we were talking today when I was telling people I was going to be on their talk show. Everybody's like, oh. And I go, I know, but we keep saying we have all these people out in the community with these myths and biases. What a better way to try to educate them while you have that opportunity on the phone with them, with that, you have that one-on-one attention with them. So hopefully I'll have that opportunity to do that, because they've had their share of myths and biases. They don't understand about addiction, so it's good that they've invited me, because I feel like I can educate them and they can be educating our community and the public that listens to them every day. So it's been a journey. It's been very eye-opening for me. There's so much that's going on in our community that I'm so proud to share with you. Some of the things that we're doing, some of the things that we've seen and found out during this data collection that's been very eye-opening for me. But I think one of the most important things is, how did we get here? How did we get this heroin epidemic? Well, in 2012, we passed House Bill 1, okay? We needed something, and I'm not blaming House Bill 1, so don't think, oh, she's blaming House Bill 1. We needed this bill. We needed to cut down on the prescription abuse bill that was happening. We were over-prescribing narcotics. We were doing it in the emergency room. Our primary care doctors were doing it. Orthopedics, just about anybody was over-prescribing narcotics. So it was really important for us to have a bill. We had to cut down on what we were prescribing. What the impact gave us was fewer pill mills, which you've seen, because now we have a lot of addiction to heroin now. We have new pain management clinics that are owned and licensed by medical providers. There's a lot more standing orders and a lot more constriction around these clinics, which is huge, because before there was no control, no reporting issues. We had no handle on what was happening in the state. More CASPA reports. Does anybody know what a CASPA report is?
Isn't that like the thing that tracks if when you get your medication like at a pharmacy, like what?
Yes,
whatever.
absolutely. We have to run a CASPA report on anybody who comes into our emergency room that we have, that we are going to prescribe narcotics to. We have to find out, do they have a primary care doctor they're getting narcotics? Have they been getting prescriptions? You would be amazed at people that still try to use the emergency room and hospital and doc shop, not realizing that we have electronic medical record now. I try to tell them, they're pretty much an open book now. We can see all their history. Before, you would have to phone call, which we weren't allowed to do, other ERs to say, this person's hospital shopping. But now I try to tell patients when they call me all upset, well, they looked at this, but you're an open book now. We can see your entire history. Same way with Casper. We just had a girl, we actually were getting ready to write her a prescription for narcotics because we hadn't had her Casper report. Her Casper report came back where she had just got 90 pain pills 3 days before. And if we wouldn't have ran that report, we would have in turn gave her more narcotics in the emergency room. So of course the hard conversation then it ends up being is we can't prescribe her anything because she just got all these pain pills. There is a concern with that because the Casper report tells you who's getting them, but it really doesn't tell you who's using them, right? They could be selling them, they could be diverting them to other people. So that's a big concern, and that's really another reason why House Bill 1 was so important, because there was a lot of diversion of drugs. People weren't just going and getting on narcotics for themselves. They were getting on them because it's a nice profit, and they were making a lot of money selling their pills. A Percocet tablet can go anywhere from $10 to $20. It's cheaper than heroin right now. So it was a big challenge for us. So it expanded the laws in the Casper reporting, and it has really hugely helped us in the emergency rooms because we now have to have that tough conversation with patients, but at least it gives us an opportunity to say, we can't because there's this new law passed and we have to run this report. And we have that conversation to them about addiction. And we're concerned. We don't want people addicted. It leads to a lot of other issues. And so we're able to start having those conversations that we didn't have before. So now that we made it a lot harder to get the pills with House Bill 1, and a lot of our patients are addicted to heroin and other opiates, really came from the stem of the pain pill mills because they were addicted to pain pills prior to just going to heroin. There's a progression here. It's not like, one day you're going to wake up and shoot IV heroin. You usually can start with cigarette smoking to marijuana, then to the pills, and then gradually you'll start snorting heroin to the point where you're not getting your high anymore, and then you're going to start injecting it. So that it's kind of been a progression there, and that's why, and a lot of them do it for pain relief, and I'll explain to you why in just a few minutes. But now that it's a lot easier to get pain pills, it made it a lot easier for them to get heroin. So a little bit about the heroin history, and I'm glad we have different ages in here because I end up tending on when I share some of this, everybody's like, this is not a new drug. In 1874, there was an English chemist that synthesized heroin from morphine. And in 1898, Bayer Pharmaceutical Company produced heroin commercially and placed morphine due to the problems with morphine abuse. So they developed heroin in place of morphine, okay, in 1898. And then in 1903, heroin addiction rises to alarming rates. Where are we now, folks? Back to alarming rates, right? It's amazing. You always think these things don't ever come back in fashion. Bell bottoms, hairstyles, and all that. The same thing happens to everything else. It's been in nursing 21 years, and I'm thinking, we did this, 10 years ago or whatever, and now it's a new fad again. Same thing's happening with heroin addiction. So in 1903, it raised to alarming rates. Excuse me, in 1905, heroin was classified as an illegal drug in the United States. And some famous overdose deaths, Janis Joplin died of a heroin overdose. John Belushi did speedballing, which is heroin and cocaine, and also River Phoenix in 1993. And there's more celebrities to date that have died from a heroin overdose. I will tell you, if you look at like John Belushi and River Phoenix, who died from the speedball, which is the heroin and cocaine, we are seeing a lot of polysubstance drug use. And what I mean by poly, meaning more than one. They don't just have heroin in their system. They have alcohol, marijuana, cocaine, Xanax. It is a very big plethora. We just recently got the state's report for the heroin deaths in Northern Kentucky. Of course, which rose, which isn't surprising. I'll share with you on our heroin overdose numbers are rising, so you don't expect the deaths not to rise. And the only thing I don't like about it is, remember when I told you that heroin is made from morphine, right? Well, they classify the heroin overdoses. These are strictly heroin, then you got your morphine, and you got your other opiates. But my concern is a lot of these people are dying from polysubstance overdoses, so are we really truly capturing the people addicted to heroin in our overdose numbers? I honestly think the number that's reported is higher. The other thing is they don't do an autopsy on every patient. If they know that they're a heroin user and that they died from a heroin overdose, they don't always do an autopsy on those. They still would be able to report those out through the state, but you just wonder how valid that reporting is with all the polysubstance use. So what is heroin? Well, it's a drug made from morphine and its natural substance. It comes from an Asian poppy plant. It usually appears in a white and brown powder, and it can be injected, smoked, or snorted. And I will tell you, we have just as many heroin overdoses snorting heroin as we do injecting it. Now, I will tell you, when I started collecting data back in 2011, a lot of our heroin overdoses were primarily from injection. They were. I didn't see as many snorting, because they'll tell us. I mean, in the nurse's narrative, it tells you pretty much why they came into the emergency room. But now I'm seeing almost a 50-50 split. We have just as many people snorting heroin and overdosing as we do injecting. I'll tell you, some of that comes with the stigma and the bias, because they don't want you to see the needle marks. They don't want people to know they're addicted. They want to try to hide their addiction. You know, it's still a shameful, disease, and no one wants to talk about it. So although pure heroin is becoming more common, most street heroin can be cut with other drugs such as sugar, starch, powdered milk, quinine, and even fentanyl, which is another narcotic that they're using, which is very strong. You just keep seeing more and more sophistication of the drugs coming out there. There's this new other synthetic heroin thing that they're calling flac, which is causes a lot more hallucinations, kind of like the synthetic, which they're not really called synthetic marijuana, but like the K2 and the spice, causes a lot of hallucinations. When you do heroin, what I call it is, and I don't know if it's in the next slide, but it's kind of like playing Russian roulette. You're pretty much spinning the wheel, and you're trying to determine, is this going to be your chance where you're going to overdose and die, or you're going to live, and you're going to get the high from it. And the reason why it is like that is because this is not a 325 milligram aspirin, okay? This isn't FDA approved, and you have no idea what you're putting in your body. You have no idea what they're cutting this stuff with. And that's the scary part. People get these drugs from different dealers and everything else, and they have no idea what compound they're made of. Here's a picture of the brown and white heroin. Here's a picture of black tar heroin. Black tar heroin is also in our Northern Kentucky community. This is the one that's primarily injected, but it looks like a little piece of coal. If it was sitting on your kid's dresser, you would not even think like that was heroin unless you knew what it looked like. Because it does. It looks like a little piece of a rock, like a little piece of coal. Just like in the white and brown heroin, I think I got a picture of some. There you go. Picture here with the baggies. We just recently had a young girl come in through the emergency room. She was kind of, I don't know, she was working with law enforcement, which I don't agree with necessarily either, because you're also taking addicts and trying to get them to work with law enforcement, but that's just my own personal opinion. But anyway, she ended up wanting to get high off of what she bought, but she was also being wired at the same time. So anyway, she swallowed the baggies, okay? And we had to give her, a lot of laxatives and all that to try to get them to come out the other end. But if one of these had ruptured in her, she could have died because of the potency and the thing. So we see a lot of them in the baggies. We also see them in colored balloons. So they just roll them up real tight, and we see them. They'll take off their socks, and we'll find them usually when they come in for a heroin overdose. The thing is, we see a lot of needles with the IV drug use, but they don't need, a lot of people think that they need now like fire or whatever, and you see all the spoons. You do still see some spoon use, but really it doesn't take much to liquefy this heroin. So you can use like your bottle top cap, and just a little bit of water in that dilutes it right up, and they can inject it that way. So, one of the things that law enforcement asks to look for is like, a lot of bottle cap lids all over the house. Because they can dilute their heroin right in that as well. So it doesn't take much to liquefy it, and it doesn't always take heat. And there's my picture of the roulette wheel. So it's like being in Vegas. You're going to spin it, and you're going to determine, is this something that you're going to risk your life for? So what are some signs of a heroin overdose? Well, first of all, they more or less get shallow respirations and a weak pulse. They still have a heartbeat a lot of times, but it's very faint and very weak. The first thing they're going to quit doing is quit breathing. So they're going to turn blue. Their lips are going to get blue. Their nail beds are going to get blue. But before that all happens, they start in their nervous system, what they'll start with is some disorientation. Nodding off is a big key. They use that word nodding off a lot. You start having a conversation and they, are nodding off. And then they'll go into the non-breathing, to the shallow respirations, to the slow, difficult breathing. If you talk about heart attacks, what's the first thing you want to do if you know you're having a heart attack? You want to get to the cath lab, right? You want to open up those heart vessels. We always are like door to balloon, which we call, door to open up those vessels is 90 minutes. We have a window. We have a standard window that's that's like best practice. It says in 90 minutes we need to get your heart valve open. We don't have a best practice for Narcan and how fast we should give it to you. We should be looking at it that way. But time is muscle when it comes to your heart as far as getting you to the cath lab, just as much of it is getting you oxygenated and giving you Narcan, which we'll go into detail a little bit more about saving your life from a heroin overdose. Because it's your brain that's being affected. You don't get oxygen to your brain, you get what we call an anoxic brain injury, which can leave you with symptoms of like having a stroke. You cannot be able to walk again, you might have weakness in your arms, you might have a real unsteady gait, you might have slurred speech for the rest of your life. So it's just like cutting the oxygen off to parts of your brain that allows you to function every day. And that's what happens with a heroin overdose. Their pupils get real small, real tiny, and it's amazing. Once you then give them the Narcan, you see their pupils open right up. So you know that they had an opiate in their system. They have a low blood pressure and a weak pulse. So what do we use for heroin overdose? Well, we use Narcan. It's also called naloxone. This is an older picture of one, but we actually use, and I don't know if you guys have seen them, so the 2 milligram, it's 2 milligrams per 2 ml, and it's in an orange thing, and it's the reason why I like it, it's an all-in-one system. So you can put like we have an all needleless system in the emergency room anyway, so you can put on a cap and push it in through their IV, or you can put on a nasal atomizer and give it nasally as well. The thing about Narcan, which is really important, we have a lot of Narcan in our community right now. It's a huge harm reduction piece of thing that we're using. But the onset, it usually takes 1 to 2 minutes IV and 2 to 5 minutes IM, sub-Q, or even nasally. The half-life, though, which means that it only lasts in your system, it's short, is only 30 to 90 minutes, and it could last up to 3 hours in neonates. The thing about that is, so if you give somebody Narcan, and they're refusing to go to the hospital, and you turn around and say, well, they're all right, I'm going to turn on leave. Well, 30 minutes later, within 30 to 90 minutes, they could relapse and go right back into a coma and overdose and die. We have had to repeat Narcan in the emergency room on patients on multiple occasions. They've been given it in the field, they come in the emergency room, they might be a little bit awake, we have to watch them minimally for an hour and a half. Why do you say we watch them for an hour and a half? Because we have to at least get past this 90-minute window. We need to make sure that they're stabilized for that first hour and a half before we feel comfortable discharging them from our emergency room. Because we know, and this is that the half-life is only 90 minutes at the max. And that's really important because we can't afford to discharge somebody and then they overdose again in the parking lot that we just pulled them out of. So what are some symptoms of withdrawal? Because when we give them the Narcan, they're not really happy with us, okay? And that's understandable. We're reversing their high, but we also save their life. But they're not worried about their life right now. They're really worried about getting sick because they will tell you this is the worst thing that they ever want to go through. They say this is worse than having a flu 10 times over, is going through withdrawal from an opiate, especially heroin. Like I said, I've been in the emergency room 21 years. And we've had alcoholics and other overdoses and stuff, but not the fear of the withdrawal than we do with the heroin addicts. And it's because it makes them so sick. It's the nausea, the vomiting, the body aches, the chills, just total flu. And you know how bad you feel if any of you had the flu. You're thinking, oh my goodness. Well, take that 10 times over, and that's what a heroin addict would feel like when they're trying to go through withdrawal. We do manage their symptoms with withdrawal in the emergency room. So we'll give them Zofran for nausea. Sometimes we'll give them some Klonopin or some Xanax just to help relax with some of the tremors and things that they're going through. But we have to be very careful about managing those. One good thing that we've done with Narcan that we didn't do in the past was we used to just shove Narcan right in their veins, like 2 milligrams, no questions asked, because we're trying to save lives. well, we would throw them in such a violent withdrawal that there was no rationalization with them. You couldn't talk to them, you couldn't rationalize with them because they're just like ripping the IVs out and ready to walk out of the emergency room. So we started to titrate the Narcan, and our EMS does the same thing. So we titrated to stability and to make sure that the patient's stable, but we really don't want to throw them in withdrawal. Because to be able to rationalize and help get resources as somebody in withdrawal versus somebody who is, stable and able to listen to you makes a big difference in our world. Plus, they're not fighting with you, they're not angry, they're not cussing and screaming and ready to leave. We actually have that golden window then that we can try to rationalize and talk to them. So that's been a big difference, I think, in our healthcare community, is that when we're watching that withdrawal, because we know how bad, we've seen people go through it. We had a patient the other day, and she was like just dozing off, and we didn't give her any Narcan right away. Her mom brought her in. Her vital signs were stable, but every time she would get real sleepy, her oxygen level would drop. So she was on some oxygen, and we were trying to just keep her stable, but not give her Narcan right away. But she just would not arouse. It was just an hour late, just kept on, and finally we're like, let's just give her like 0.4. Well, as soon as we told her we were gonna give her a little Narcan, she woke up, she was like, are you kidding? I don't want this, you can't do this. And I was like, then stay awake and talk to us. And 5 minutes later, she was already sleeping again. So we're like, we're gonna give it. So we just gave her a little bit, but it's that trust issue. And I think once she realized that she could trust us, that we weren't giving her so much, that we were gonna throw her into a violent withdrawal, she calmed down and was very nice to us and very appreciative with the care when she was getting ready to leave, because we were able to help her and get her some resources. Because we understood that she had a disease, and we're not trying to just throw everybody in withdrawal and make you miserable so you think you're gonna stop. I mean, that's not our point, because we know that doesn't work either, because we've done that too. So, yes.
What is your opinion of the treatment facilities that feature the cold turkey withdrawal?
It does work. When you talk about treatment, we just brought Bedford and Hazleton in to Northern Kentucky, brought their Core 12 program to Northern Kentucky. And I just went through their training a couple weeks ago. And they have an abstinence base, and they have a medical assisted, treatment and all that. This is just like any other disease, and it needs not to be cookie cutter that says, okay, abstinence is it, that's the only way we're gonna go, or a medical assisted treatment's it, and that's the only way we should go. I think it's what's best for the patient. We need to assess these patients appropriately. We need to find out what they've done before, what might have not worked. Did they maybe do abstinence and didn't do well, so maybe they need to look at some medical assisted treatment? Or did they do medical assisted treatment and it was a failure, and maybe abstinence is what they need? It really is an individual base. So when you're assessing them, you kind of need to find out, where they've been, what they're doing, because it needs to be tailored to the individual. I don't think it's fair for me to say, only this approach or only that approach, because it's like if you're looking at other diseases with like diabetes with insulin, or can you do oral pills or do you need insulin? Well, how well do you manage your diabetes? Are you a cheater and you're not going by your diet? Then you're probably going to need sub-Q insulin. If you're pretty compliant with your diet and you're doing pretty good, maybe you can do it with some oral and oral medications and manage it. So it's still taking that disease with your other diseases and really looking at the individual to find out what stressors do they have, or other barriers to treatment that maybe abstinent might be the only way to go. I will tell you from personal experience, my brother was addicted to heroin. He's been in recovery for 1.5 years now. When we first found out he was addicted, he swore to me, I need Suboxone, I need Suboxone. And he was buying it off the streets because he didn't want to be addicted, so he was misusing it because he couldn't get a doctor to prescribe it. So he thought, I have to have that. I'm not going to be able to get through this recovery without Suboxone. That was what he thought. Then he got into an abstinence-based only program, okay? And he thought, wow, maybe I can do this without anything. And he did. He was able to do that. So he needed to experience both. He needed to see that the medical assisted treatment maybe wasn't what was best for him, that maybe abstinence was. He now looks back and says that was a good fit for me. However, unless I tried the medical assisted treatment, maybe I would have never believed that I could do the abstinence. So it really is going to be tailored individually. And I think when you're assessing patients and clients, that's something that needs to come into play, is what's best for them. What have they done? What have they not tried? you know, and try to tailor something that's gonna meet their needs. Some of these people still work, they still have normal lives, and can function, because maybe they only use a couple times a week or 3 or 4 times a week. We've seen that happen. I mean, I had a 50-year-old in a business suit, using heroin. So, you know, what kind of treatment then could they do and still be able to function and, you know, hold their job and be able to help, you know, support their family? So it really has to be tailored to the individual. That's a good question. Long answer for your question, but yes.
I was wondering, like, you were talking about, you know, they could do like the medical or the abstinence, like in the abstinent ones, do they do any like short term? Like, cause like I had gone to a rehab and, I was on methadone for, I went there and they just gave me Suboxone for like 8 days just to kind of ease into it. But then it was like abstinence after that.
Yeah, and that's what the medical assisted treatment is with the Core 12 for Betty Ford. It tailors down, so maybe we bring you in on Vivitrol and then, you know, try to get you on Suboxone or you stay on Vivitrol. So there's different tracks, and I can pull that up. And that's kind of nice too, because, you know, you do that detoxing, and then you kind of like, so you need a little bit stronger dose, but once you detox, then maybe you can like start tailoring down your Suboxone to the point where you can get to an abstinence-based program, or maybe you need to stay on something a little bit longer. I know when Dr. Kalfas, he's the expert in that, he will be here next Tuesday with you, and he will be able to explain a lot of the medical assisted treatment. I don't want to steal his thunder, so I'll let him do that next Tuesday. But he's an expert at it, to be honest with you. He's awesome. He tailors it to the individuals. He know, you know, and what their needs are. But that would be a good, you know, good thing for him too, because, you know, he has a lot of patients that he takes care of that function, you know, daily too, and trying to get back to their normal lives. So.
Yeah. Assuming this is coexisted with a chemical imbalance, is there any, as far as you're concerned, is there any scientific method to determine a chemical imbalance versus this? I mean, bipolar, I come in there, you know, and I'm questionably bipolar, you know, bipolar, you go on a spending trip and not even know where in the hell you're going and spend every money you have, all the money you have, versus a heroin trip, you know. So how quickly or whatever, by what methodology do you determine or differentiate?
It comes with an assessment. Our intake coordinators will do an assessment, and entailed like face-to-face assessment. And a lot of those questions are in there about the dual diagnosis, about the mental health piece, and where they've been and how are they doing with that. I don't assess that part of it, but I'm sure I can get some information to Bonnie to share with you. But there's assessment tools out there that they use to try to determine, you know, what else is going on, you know, what else is going on with the mental health part. Because what we call then is like dual diagnosis.
Dual diagnosis.
Right, so we see a lot of that. And you know, and it's pretty sad. We had a young girl the other day, we were trying to get into treatment. She wasn't suicidal, wasn't homicidal, just was truly just addicted. We've called multiple treatment facilities, and one of the big things is, well, is she suicidal? We're like, no. They're like, well, we can't take her. It's because, you know why? They wanted that dual diagnosis. Because you know why? What do you think you're going to get reimbursed for? Just addiction or mental health and addiction?
No.
It's sad. Yes.
No, my
Yeah.
goodness.
It's sad because this is what our insurance, I mean, this is where we are in this world with our insurance. I think that we woke up Kentucky with House Bill 192. They are really listening. I think for the first time in years, don't you feel that way, that they're actually taking notice about what's going on, and, you know, getting more assistance from Medicaid and getting them to understand with the you know, the Obamacare, which I'm not really supposed to call it that, but the Affordable Care Act, because they know that those are the people that need treatment. So how are they going to cover that? But a lot of it does come down to dual diagnosis. And if you talk to like our mental health folks who end up screening these patients and their clients, there is normally an underlying dual diagnosis. You know, either it could be depression, anxiety, you know, other stressors, you know, finances, job, economy. So, but it's sad reality. They look for those dual diagnoses because the reimbursement's better.
And you don't work with the military, the Veterans Administration, where you probably get some spillover from there, because
Yeah.
I know I go over to VA and I don't see any literature none whatsoever on none of this. I see literature on sexual assault, stress, et cetera, and I just asked the gentleman, Donald, here last night about this, and he says basically it's like the Vietnam veterans are still falling through the cracks with this stuff, and it seemed like the VA, the Veterans Administration, is going to turn their back. I would never know this kind of stuff existed by walking through the VA.
Yeah.
Never know it existed.
Well, some good news is they did reach out to us to try to help them with some education. So hopefully that's a step in the right direction for them. I work at the Fort Thomas campus, so we're right
there a few times
yes,
myself.
so we're right by the VA there. So we try to help them, get into those resources.
Oh,
but
yeah.
I agree with you, it's a challenge.
I come there because the VA didn't work.
Yeah. Well, and we hear that a lot, and that's sad. Because and then or they don't have beds, so can't get you admitted. But it's a sad thing that we're doing, absolutely. So how does it affect your health? Well, heroin affects a lot of things. It affects your heart. You can get a heart valve infection called endocarditis. It's very expensive to treat for endocarditis. Collapsed veins, for you coming in through the emergency room and you don't have any veins left, it makes it a little bit difficult for us to care for you and especially resuscitate you if you're not breathing. Liver disease and hepatitis C, which we'll talk a lot about. Brain and addiction. It does create a strong addiction by using heroin, and I'm going to go over that a little bit more in detail. Lungs and pneumonia. We see a lot of we've seen some lung abscesses in an adolescent for snorting heroin. We see a lot of aspiration pneumonias, which causes a nasty infection in your lungs. And the reason why is because when they overdose, then they'll aspirate on whatever they were eating or drinking. It gets into their lungs. It's foreign body in there. So it's trying to fight it and end up getting pneumonia. Can end up in the ICU. So even though you might have survived the overdose, you're going to end up having some medical complications related to your heroin addiction as well. And of course the skin abscesses. That's a big thing that we're starting to see more and more of. It is a big challenge for us as healthcare providers to be able to take care of a patient who has a skin abscess and then they have to be admitted to the hospital. Even though we have some resources in place, which I'll share with you, you're asking a patient who's addicted now to stay in the hospital with an IV in for IV antibiotics when they can't use it for anything else. It's a big challenge. I got a question the other day, which I thought was awesome. It's like, do you put any kind of device or anything on that so it's tamper-proof or tamper-resistant? And I thought, no, but I better get working on patenting something so I can retire early. Because I'm thinking, oh my gosh, what a great, I can look, I don't know that anything's out there, so I was like, oh, that's gonna research check, that might be one that I'm gonna look at. But that's a big challenge for us as healthcare professionals. You're putting a patient in with addiction, you're asking them to go through a draw in the hospital, you're trying to manage their pain and you're trying to manage them medically, and it's a big challenge for us. And I'll share with you a little bit about how we're managing that. So a little bit about the data. So remember when I told you that House Bill 1 happened in 2012, right? Well, what was happening in 2011? Well, we still had a heroin problem. We had 252 known heroin overdoses in 11. If you talk to Charlotte Wellington from Casey's Law, this is, like I told you before, this isn't a new drug. We've had it, when I was working at Covington back in the 90s, we used to have kids from Lexington, UK, come up through here, get their drugs in Cincinnati, overdose at the Covington Shell Station, and end up in our emergency rooms. So this isn't new. We just haven't seen the numbers like we're seeing because after House Bill 1 and the pill mills got kind of shut down, then it kind of just escalated. Because they needed a void. They needed, where else are they going to get their pain pills? What are they else they're going to use for the help with their pain and their addiction that they already had? So that's when I wanted to go back, and when we started our electronic medical record, that's why I didn't go back any further than that. And then in 2013, we saw 545. Last year alone, we saw 745. I didn't bring the most updated slide. I thought it was on my flash drive. But I will tell you, already through June, and this is just our St. Elizabeth, Northern Kentucky ED system. So this is Grant County, Florence, Edgewood, Covington, and Fort Thomas. So it's just the 5 EDs. I look at all the known heroin overdoses. So I actually open up every medical record. I look to make sure that either they admitted it, they were here for heroin overdose, or they had a positive drug screen for heroin overdose. So this isn't our other opiate overdoses who got relieved with Narcan, which Narcan only works on opiates, okay, nothing else but opiates. And they say, oh, I didn't take anything. Like, those aren't even in my data, and I probably have 20 plus overdoses that are opiate that fall into another category every month as well. But 745 known heroin overdoses. Year to date in 2015, we're at 565 already. We had a record May. We had 132 known heroin overdoses in May, this past May. I was pleased to look at June numbers because we actually saw a little bit of a decrease from even prior year. I think it was in the 60s, which is, I like double check the data. I'm like, how do we go from 132 to 60 or 70 or whatever, that I don't remember offhand the exact one, like the exact number. But it kind of was alarming to me because I'm like, how do we do that? Well, you don't know what's happening in the community. You don't know like what dealers have changed or what else is going on. Do we have more deaths in that month? I won't know that right away. Maybe we had more deaths than we did overdoses. Maybe more of our residents in Northern Kentucky ended up at UC versus our Northern Kentucky hospitals. But yeah, we had 53 in June. You know, I double and triple check my data when we have a high number, and I do the same thing when I have a low number. There's no rhyme or reason right now. I hope that 132 was our peak, and we're done from there, and we start seeing some steadying out in this overdose data.
That's over the big area, not just St. Louis.
All 5 St. Elizabeth hospitals. This is just St. Elizabeth data.
Fort Thomas, Covington,
Grant County, Florence, and Edgewood.
Florence, which is Campbell, Kenton, and
Boone,
Boone.
and then you got our rural counties. So that's all the rural counties and Campbell
Go down
County.
as far as Falmouth.
Absolutely.
And Falmouth's pretty hot down there.
Yeah, it's everywhere. I mean, it's literally everywhere. I think that Covington, Fort Thomas, and Florence see the most overdoses, and it's because we're on all the major highways. We're right on those corridors, and that's kind of where they end up at, R3R. Edgewood Emergency Room sees, besides Grant County, which is the lowest number of heroin overdoses, Edgewood is second lowest, and then the other 3 of us can kind of play cat and mouse on ties back and forth each month. So, yes ma'am.
What was the number you said for year to date?
565.
Ugh.
Yeah, we're gonna see over 1,000 heroin overdoses this year. I mean, there's no doubt.
Over 1,000?
We're on track, we're on pace. Yeah, because for the first 6 months, we've already had 565. So, and I will tell you, our age range is anywhere from 16 to 60 plus. It's amazing. We have a 60-something-year-old who is addicted to heroin. He was addicted to pain pills, so his son thought, well, I can't get your pain pills anymore, Dad, so I got something better for you, and he gives him heroin. He's been in our ER a couple times for a heroin overdose. We kind of have taken care of the family, and many times. That's a generational thing that, you know, we're going to look at some of that data next is, you know, how did you get started? You know, and kind of try to put them in themes. You know, was it a social thing? Did you start with other classification drugs and all that? Because we really got to figure out, like, no one really talks to the people addicted. You know, unless they get into treatment or whatever, we're missing a whole boat of understanding of this disease. And who better to give that to you than the patients that we're taking care of? So we're going to look at that a little bit differently. But, you know, looking at this data though, it's just overwhelmingly alarming that it just keeps going up.
How many of those resulted in fatalities?
I was going to say greater than 90% of the ones that come into our emergency room don't even get admitted. They get discharged right back in the streets because of Narcan. You know, we are saving a lot of lives with the Narcan rescue kits, but the majority of them, I don't keep any of the death statistics because if they come in as a DOA or died in the ER from the field, I don't know that that's heroin until they get the coroner report, so I let the state come up with the data for the state overdose deaths. only because, so I just track the overdoses that come in. And like I said, over 90% of ours are discharged right back in the community. The other 10% a month are usually admitted to our ICU, which could end up at death later. So those are in here. I have another student coming next semester, so I'm taking like students, like I have a, well, I only take nursing students, sorry, I'm not licensed to take social worker students. I've tried to get one, and I farmed her out to somebody else to help me. She's still gonna work for me, and kind of like, anyway, we're gonna go around. But anyway, because I really wanna look at, you know, one of the things that we're getting asked for a lot now is counties. You know, how, you know, what county is being affected more than the other. My only thing that you have to look at, there's a couple things that we have to look at when you're looking at counties though. They could live in Boone and ended up in Campbell County as a heroin overdose. And that's because they bought their heroin over in Cincinnati. You know, they could be a resident in Fort Thomas, but then knows a dealer in Florence. So when we look at this, we're gonna almost have to do it by zip code and then arrival to ER. So it's gonna be it's kind of hard, because just because so it's really, we're gonna have to look at it as if they're a resident of that county, not really the overdose happened in that county. How many residents in that county have an addiction issue is I think what we're gonna look at. And that's if they gave us a valid address and zip code, but at least gives us a starting point. We did a snapshot last year, and I don't think I have it on this one, but I wanted to look at, so we just did a snapshot of the previous year. So in 2000, we did it actually in 2014. We took a snapshot of, you know, what are we seeing as far as the heroin overdoses. I will tell you that it's almost 50-50 as far as male and female. So it's about a 50-50 ratio. 33% of them, the heroin overdoses that we did data on, were between the ages of 16 and 25. But the majority of our heroin overdoses are 25 to 35. We're going to lose an entire generation to this heroin epidemic, and especially in that age group. That is where the majority of them are coming from, that 25 to 35. That's where our deaths are coming from. That's the ones who are not saving, is that 25 to 35 range. You know, like I said, we've had people older than that addicted to heroin because they were addicted to pills. You know, I told you about the heroin overdose in the business suit. He was addicted to pain pills, had a chronic back issue. Couldn't get his narcotics anymore. His doctor either got in trouble or got fired. I can't remember what happened. And one of his buddies said, well, I can't get you your pain pills anymore because they're getting me too expensive. However, why don't you try this? And he gave him heroin and became addicted after that. So he used it just like he did for his pain medication. He didn't need to take it every day, but he was snorting heroin. But like with the pain pills, that's FDA approved. You know, when you're getting a Percocet, it's a 5 milligram, you're getting 5 milligrams of Oxycontin and 325 of acetaminophen. You know exactly what you're getting. Heroin is not FDA approved, and you have no idea what kind of combination you're getting. So he was so embarrassed, very remorseful, very, trying to figure out, didn't want us to call his wife, which is understandable. He was very receptive to resources and stuff. But I think that was a wake-up call for him, because even though he was addicted to pills, he didn't think that he was ever going to overdose or anything. But then when he got this heroin and realized, oh my God, this could kill me, because you don't know what you're taking. I can't tell you what your dealer mixed it with or what he didn't mix it with and what the purity is. We have no idea, and that's the scary part about it. So when we talk about hepatitis C, the rates of acute infections of hepatitis C in Northern Kentucky doubled the state's rates and were 24 times higher than the national rate. I spoke in Kentucky last year down at the state level, and I almost had to apologize to them because Northern Kentucky's driving up the entire state's rate of hepatitis C. So it's us in Northern Kentucky that are driving up the entire state. And that's pretty alarming. And you can see here the difference between the state of Kentucky and Northern Kentucky on that. And that's older, it's 2012, and we're still on a huge upward trend. You all know what happened in Scott County in Indiana with the hepatitis, the HIV epidemic. It's alarming. And I will tell you, and I told Dr. Salas in the health department, I think the health department knows, we're right around the corner from that happening here. I wouldn't be surprised if we're not facing that in the next 6 months to a year or less. Because,
you know, we have the same population of patients. You know, we're not immune to this. If our hepatitis C rates are this high, I guarantee you our HIV rates are going to be climbing as well. That's why, is anybody going to be talking about needle exchange?
Oh, yeah.
Okay, you got somebody, oh, you already had your needle exchange? So, you already knew about the hepatitis C rates, you could have stopped. But great stuff. You know, that's another thing, you know, educating the community on, you know, being able to cut down on infectious disease. Yes.
I had a question, because I've heard different things. Can you get hepatitis C from sharing like straws or pills that you're like snorting with? I've heard some people say that you can, some people say you can't.
No, hepatitis C is blood to blood.
Okay, but I mean, like, even like, you know, so like your nose, like
Well,
when you're
like-
snorting, your nose can get all. You know,
Right, you got
stuffed.
bloody, you opened up all
Yeah.
those mucous membranes, so you're more exposed to that because
Yeah.
it's all, you know, you have all those blood vessels in there and mucous membranes. And, you know, if a guy, you know, think about it, you cut your shave, you know, shave your face, your legs and then bleed, you know, you have that risk, absolutely. But it is it's a bloodborne transmitted disease. Because that's what a lot of people ask about, like, as far as that goes, but it is bloodborne. But that's a good question. So I'll move on. When do you want to take a break? Is it about time?
Do you need to take a break?
No, fine.
I think we're good
Okay.
for a few.
Okay, just let me know. Oh, here's the snapshot that I was talking about. Let me see if I'm still right. Oh, I even memorized all my lines. So that's good. And one thing that I wanted to say is, you know, we're in northern Kentucky, so our population is pretty different, but, you know, 96% of the patients that come in through our ED system are white. You know, we're strongly Caucasian users of heroin in northern Kentucky. We did have 1% that were African American and 3%, or excuse me, 1% that were other and 3% that were African American. But, you know, across the river, their demographics are a little bit different. And then if you look at, so it's just important to know, because somebody asked me, well, do you think this is, you know, Caucasian use of a drug? Well, in northern Kentucky, that's primarily what we're seeing. I can't tell you what's happening in other parts of the states, but I will tell you there is deaths in other races too from heroin use. Here is, this is a little bit older. I haven't really even gotten a new one lately. But remember when I was telling you that, so we have a lot of patients with Northern Kentucky zip codes that end up at UC. Just as I, in Fort Thomas, have a ton of people from either, not as many from Cincinnati. It's kind of weird because when we did a snapshot, we didn't really have that many from Cincinnati in our neck of the woods as far as Northern Kentucky overdoses. However, we did have a lot of Indiana. And the reason why is because they'll buy it in Cincinnati, shoot up on their way back over to Northern Kentucky before they can even make it home to the other bridge to get them back to Lawrenceburg. So we're starting to see that more and more, especially at Florence and then at Covington and Fort Thomas, because we're all connected right there on that major highway for them to get back. But you can see here at UC, they collect data scores too, but these are the heroin overdoses that had a Kentucky zip code. And you can see that, you know, there was 600 overdoses in 2011 that had a Kentucky zip code. Now that could be any part of Kentucky. Like I tell you before, when we first started collecting data back in 2012, I was talking to one of my physicians who actually lives in Georgetown. And he was telling me that it really isn't talked about much. He was kind of surprised that we were getting a task force together, we were collecting data and looking at all this. I go, it's on its way down south. But to be honest with you, your Georgetown and UK kids don't have a problem finding it because they're coming all the way to Cincinnati to get it. It's going to be soon enough when they end up getting it down in Lexington, and that's just exactly where they're at now. Fayette County and then Louisville and Jefferson County, they're feeling the effects that we've been feeling for years. It just took a little bit longer to get down to them. But they've had a heroin epidemic just as long. So that was kind of interesting to see. So what is addiction? Well, it's a compulsive need to use a habit-forming substance such as heroin, nicotine, alcohol, characterized by tolerance and well-defined psychological symptoms of withdrawal. And what I mean by this is you get sick. You know you have an addiction issue that when you stop using, you start to go through withdrawal. Okay, that is when you know you're addicted. Well, when you start having the nausea and vomiting and that you have to use the drug or the alcohol or whatever to make your symptoms go away and feel better, you now know you're addicted. You know now that this is an addiction. any single use of heroin can start a patient or a person on a road to addiction. And I think that's really important. Like Bonnie said earlier, I kind of started with, I've kind of taken a full circle approach, right, to this heroin epidemic. I started collecting the data, which kind of led me into talking to the healthcare professionals in the community, which then Bonnie graciously got me involved to some of the schools. And then it's just kind of grown from there. Our youth is still at risk. I mean, we have a lot to do as far as education. They still think they're invincible. They still think that, smoking marijuana isn't going to lead to any other drug use. It was amazing. I had a conversation with a parent the other day, and they are still condoning marijuana use, which I just wanted to smack her, but I couldn't do that. But at the same time, when I educated her on how much THC was in marijuana, this isn't the 60s marijuana anymore, that the THC is, almost tripled and quadrupled from where it was, which is the addiction factor in the marijuana. I think that was an alarming wake-up call to that mother. I've educated, this past year, I really had a mission where I'd educate parents on a Sunday night and the kids on Monday, so that they could go home and start talking about it on Tuesday, or Monday night, really, which was our goal. And it's amazing to hear parents not even understand what's happening and what's even going on. So it's kind of alarming now. That's like, I think that wake-up call to her was like, you're kidding. And I'm like, no. And you don't know what they're lacing it with. There's that synthetic marijuana. I mean, they're lacing marijuana with cocaine and heroin. They want these kids addicted to something else. They want to get them addicted stronger. They want them to come back for more. So they're going to do anything they can to get these kids addicted. And that because they want to have more people addicted, because that only helps them, right, make their money and pockets bigger too.
What do you think is the reason that communities, they want something done about it, but nobody wants to do anything about it? Like, we had Northern Kentucky Hates Heroin come to Pendleton County. Dr. Kalfas came.
Yeah.
Were you there?
I'm not sure. I've been everywhere. I could have been.
I think you were there.
I might have been.
It was. I think it was in May or June.
Probably.
And like 50 people from our community showed up. But then there's
Oh, yes, you guys had a great showing. That's right. You guys had a great showing at your town hall.
No, at the town hall meeting, yes, but not, this was outside, and we,
It was their community heroin awareness day back in May.
Oh, okay.
I
I
don't know.
was at that
You
one.
might not have been there.
we had nobody. Like 50 people came. But yet, anybody you talk to on the street, or at the grocery store, or at the beauty shop, says, what are we gonna do about this? Well, by God, you had the perfect example of where you could learn all this, and you just chose not to.
Well,
But yet you're gonna complain.
well, it's not socially accepted. You say my son or daughter has cancer. Everybody's like, oh, I'm so sorry. You're not going to stand up in the community and say, my son's addicted. My daughter has addiction issues. Because no one knows how to react to you about it. Because we're still biased and thinking, oh, what did she do as a mother? That person's addicted. Or what happened in their family that went wrong? We don't accept it as a disease. That's why no one wants to really put themselves out there. I'll tell you, when my brother got addicted, my mom was like, oh, no one's going to know about this. Well, my mom's 68 years old. My dad's retired. My mom's, still working full time. She wanted to sweep it under the rug and didn't want anybody to know about it. I'm like, oh, no, absolutely not. We're having a big family meeting. The grandkids are going to know. Because we have to talk about this. You're not going to help him if we just say, oh, he doesn't really have a problem. We're going to sneak him into treatment. We have to get families to start talking about it, not be afraid. It took my mom probably, and I know she's embarrassed by it now, but it probably took her almost 9 months to even say it out loud that she had a son with addiction issues. Because she was embarrassed. She didn't want to tell her boss. She didn't want to tell my grandfather. I mean, she did not want to talk about it. Because then she felt as a failure to her. Like, what did I do wrong? I have 5 kids. How did this happen? How did I not see this under my own roof? She was not educated on the warning signs. Oh, he's sleeping. He's tired. Or, oh, he got laid off again. I mean, she's like, didn't see any of that. And our society is so... We had this big regional meeting today, and it was so eye-opening because culturally, we have not accepted this disease. We truly still have not. Yes, it's getting better. I feel like we're getting somewhat better as a community, being cultured, and the only reason why, and the sad thing is why, is because more people have been affected by it. Those are the only people that are gonna talk about it. But they're still embarrassed, they still don't want, a lot of these communities are small, they're close-knit, their kids all went to school together, they don't wanna tell anybody that their son or daughter's addicted, or that they know, that so-and-so's friend is. I know physicians who have lost their kids to addiction and still don't really wanna talk about it. But it's just, we haven't culturally accepted it yet. There's a lot of stigma, there's a lot of bias. Why can't they just quit? Why can't they quit using? It's like telling somebody who, I can't tell you how many times I've dieted and I've not been successful, but I'm going to try and diet. Same thing with addiction. The treatment might not work the first time, but if you're willing to try again, we will find something that'll work for you. Just like when you diet, you know what you have to do to eat healthy and to exercise, and a combination of both. A miracle pill is only going to work you for so long, and then when you get back to your normal lifestyle, you're going to gain it all back. We all know these things in society when it comes to other things, but we just don't treat this addiction the same way. And that's the sad part of reality. And that's where we have to start doing, and you guys start doing, is, getting more people to be, more desensitized to it, to where they want to come out and talk about it. You have your grassroots folks. I know Northern Kentucky Hates Heroin, I think, is signed up to talk, right? No? Is it somebody who else is coming? I'm trying to look at the agenda.
Charlotte is coming with a group of people.
Oh, okay, good. So you have a lot of grassroots organizations. You have Charlotte, who started Casey's Law, which you'll hear about more, and things like that, who stood up and said, I'm not going to be quiet about it. But that's a small handful of people that need to start up and start taking notice. I think that the community really did take notice because more people have been affected by it, because House Bill 192, I guarantee this, and I still want to find this out when I call the state, I guarantee Northern Kentucky was the reason why House Bill 192 got passed. It wasn't the rest of the state of Kentucky. It wasn't Jefferson and Fayette County, Louisville, and Lexington, I'll guarantee that. It was Northern Kentucky, because we are seeing how it's affecting our community and the people that we love. And I guarantee that we're the ones who really got that bill passed. I really believe that. And I keep saying, can I get a list of the phone calls and what, because, they have a zip code of everybody who called. I keep asking for it every time I'm down there with Van, getting it. But I think it's important, because I think that we are starting to recognize it. But I agree with you. It's still hard. People still don't want to. You don't get that overwhelmingly hug and response when you tell somebody your son's addicted, because they don't even know what to say to you, or daughter, than if you have cancer. You have to think. They're like, oh, I'm so sorry, and with addiction, they're like, oh, what happened? How did he get addicted? When did he start using?
Yeah.
You get all these other questions, and it's like, wait a minute, you
Yeah.
don't get.
He didn't wake up today and say, I'm gonna
Use or whatever.
heroin.
And I hope you don't know, I'm not stereotyping like you, I'm just in general, so I
Yeah.
don't just say you don't.
Well,
read that.
the town hall meeting we had, that was shortly after my son passed away from addiction.
Oh, I'm sorry,
and,
so I didn't even know that when we were talking about this.
But my husband, I made him go with me. And, because he all the time said, why can't he just quit? Why can't he just stop using it? Blah, blah, blah. And when we left there that night, he said, wow, I never realized how sick he was. And so, if that meeting did nothing else, it changed one person's, outlook on the situation. But I advocate for it,
Yeah.
definitely, at home, and,
Yeah.
because I'm from Pendleton County, and it's bad.
Well, and I think that's important, like you said, even just getting your husband to understand it, because that probably made him feel a lot better in his healing too, of understanding what had happened, because at first I don't get it, but then he gets it, and that's where we're not there as a community though, yet, we're just not. And hopefully we will be soon. I think one thing we talked about is more, public service announcements, more community education, about addiction. I was amazed, was it one of the TV series, not recently, must have had, no, you know where it was. This is really sad. I was in Gulf Shores, Alabama on vacation, and I saw more public service announcements about addiction and where to get help than I had. And I thought, wow, that's pretty interesting. So it was that, and I thought that was pretty interesting, because I'm like, where was I? And I felt like every time I turned the TV on and there was a commercial, there was something about addiction in a public service announcement. And I thought that was pretty interesting.
You'll be seeing them by the end of the year here.
I'm sure we will. Because you're a rock star. We're gonna get it done. We're gonna get it done.
It's on the move.
So another way to describe an addiction, and I got this from Pam Easterling. I thought this was pretty neat. This is something when you were talking about, like, you know, when you're assessing your clients or your patients and you're trying to figure out like where they are with their addiction. You know, another way to look at it is the 4 C's. You know, is there a craving? Do they have lost control or frequent use? Do they have a compulsion to use? Do they use despite all consequences? And I will tell you, that is what's happening with this heroin epidemic. You know, we have moms who've lost, you know, custody of their children, they lost their families, but still can't get off of it. And they'll tell you, I know that I've lost all this, but it has overpowered me and I can't get off. Consider a person who finds either alcohol or drugs so pleasurable that they regularly go to the bar or go use with friends after work. That would be considered a craving. They escalate their drinking or their drug use until they build up a tolerance, and they experience withdrawal when they don't use, and we talked about that. He tries to repeatedly fail to cut down. That means they lost control. So they really don't want to be addicted. They do try to substitute other things to help mask their addiction and or try to cut back. They will try to do that, but then they've lost control now. So that's one of the other C's. They've lost control of their use, and when they try to cut back, they go through withdrawal, and now they've gotten addicted. They recognize that in order to function normally, they maximize their opportunities to use their drugs or the alcohol. It affects their work, their family, that's considered compulsion, and eventually they lose everything, including their job, and those are the consequences. So I like that analogy of the 4 C's because I think that's important. We share this with the nurses because, you know, patients still don't want to admit that they have an addiction issue. So one of the things we ask, you know, well, how often are you using it? You know, so we start bringing in these questions. You know, what negative consequences have you had from your use? So you're starting to kind of get them to understand that they have an addiction, but you're going about it a little bit of a different way, not just going up and saying, okay, I know you're addicted, so, you know, you're kind of understanding them a little bit better on how they even got here. And I try to explain that to a lot of our healthcare professionals too. You know, these people, you know, are good people who, you know, want to live in society and want to function, who now are so addicted that their new normal part of their life is addiction. They don't know anywhere else to live now because the only way they can live and survive and their new norm is using. They don't know what their life was like before that because now that all they can think about is their next use and how they're going to survive and not go through withdrawal. That's the only thing they're functioning about now. You know, I got a question the other day, a couple weeks ago when, you know, that dad was arrested and his kids were in the backseat. And it's like, you know, how can that dad drive with kids in the backseat? You know, I just don't understand, like, why anybody would do that. And it's like, it's not the dad making that rational decision. It's the addict who is using. He's not thinking, oh, my kids are in the backseat. No, he's thinking, I just picked up my drugs. I better shoot up or I'm going to start vomiting and going through withdrawal. And I'm feeling so sick. I'm diaphoretic. I'm feeling like crap. I'm going to go ahead and give myself an injection of some heroin so I feel better. He's not thinking, oh, my kids are in the backseat. Maybe I shouldn't do that. No, he's thinking, I am so addicted. My brain is firing, you know, 1,000 times a minute, and all I can think about is use. So that's all they're thinking about. They're not thinking about their children in the back seat. So when people start understanding that, then maybe they start understanding the addiction process too. You know, it's not like they're like neglecting their children. That wasn't the intent. The intent was to get their fix so that they can feel better. So why are the relapse rates? You know, you hear that a lot. You know, they went through treatment, you know, didn't work, you know, I don't understand how come they can't get better. Well, if you look at drug addiction, relapse rates compared to like diabetes, hypertension, and asthma, you know, drug addicted people relapse 40 to 60% of the time. And so does diabetic people, hypertension, and even asthmatics. And I think this is really important to understand. We were talking about this earlier. You know, we talk about it a lot. We have diabetics who are non-compliant, who come into our emergency room like weekly. We have the same kid. We have given him care vouchers to the diabetic clinic. We have given him free insulin. We've given him free needles. We've given him a free AccuCheck machine. We've given him everything to be successful with his diabetes, right? But he's not compliant and he doesn't care. So he doesn't care what we give him. He's not going to be compliant. And he comes in through our emergency room on almost a weekly or monthly basis because his sugars are through the roof because he doesn't want to manage his diabetes. but yet we feel sorry for them, and we give them all these resources, and everybody's so nice and caring. And then we have somebody that relapsed and said, didn't we just take care of you with an overdose about a month ago? And then we're like, seriously? You know, and we are just totally different. There's that bias, that I can't believe you're doing this again, you know, I don't understand. Well, have you ever tried to, you know, diet or exercise or manage a disease? I can't imagine being diabetic. I really couldn't. I love my dark chocolate, and I think I would really struggle with being compliant. And I think that we need to look at that. This is a disease like we do our other diseases. We're starting to get there medically. You know, our physicians are getting a lot of education. I think they're starting to understand it. You know, a couple years ago, when we were talking about it with our physicians, they were like, oh, we need them in another office. We don't need them in our patient office now. We need them somewhere else. And it was less than a couple months ago, one of the physicians stood up and said, well, it's fine if we want to manage them this way while we get started, but eventually we're going to have to figure out how we're going to manage them in our practice. I about fell out of my chair because I'm like, oh my God, the light bulb went off. They're getting it. You know, they're starting to really understand. And I'll tell you why they're starting to get it is because they're taking care of the moms, the dads, and the grandpas who are being affected by this heroin epidemic. They're taking care of the grandparents who are raising their grandchildren, and they're taking care of their patients who have children that are addicted. And they're seeing the effect that it has on them, and they realize that they need to probably understand it and figure out a way to help them. Yes, sir.
Well, a huge thread that runs through the concept of addiction in AA is that it is a physical disease. AA, alcoholism, is a physical disease. And many alcoholics stand on that premise, that platform, every time they go to a meeting. I am a sick person, no more or no less than a diabetic. So, over here, we have the heroin addict. How does this balance out? Is there many heroin addicts who say, I have a disease, no greater or smaller, I have a physical disease. So how many doctors now, in your opinion, how many professional medical doctors and psychiatrists, psychiatrists who subscribe to the physical disease concept?
I think we manage their symptoms, the physical symptoms, you know, as far as that. But as far as that, I think they're getting to know it's a brain disease. I mean, you have physical symptoms from the withdrawal, just like your alcohol, but it really is truly a brain disease. If you look at a brain that's addicted versus not addicted, you can see the pattern of how it's affected their brain pattern. So it is truly a brain disease.
Heroin as well as?
Alcohol, all those chemical dependencies are considered a brain disease.
And so it's big among the professionals, the experts, and they're very divided. I just wonder.
They're still divided.
Yeah, they're still divided. I just wonder what is the percentage now, any rough estimate?
I mean, I think we're getting there. I wouldn't say we're over 50%, but I think we're definitely in a better place than we were a year ago or even 2 years ago.
So then
with
there's-
understanding the addiction. Because you have to understand, we were just, they have not gotten a lot of education either on addiction. In medical school, we didn't get any nursing school. I know it's appalling, you would think that they would, but
Yeah.
they don't. We are looking at trying to develop more programs for them. They're putting tools together for the physicians called an expert, which is a screening tool to be able to help understand their patients and know their risk before prescribing them any narcotics or anything. But, unfortunately, it's not as fast as we'd all like it to be. But I think that they're definitely understanding it, and they want to get better at understanding it. Because like I said, their patients are being affected by it. So they need to get, more on track with that. And I think that we have a lot of good physicians, and you'll get to meet Dr. Kalpas next week, who has done a lot of great work on getting physicians to understand it. And I think that he's helped us in that avenue a lot.
I just wanted to add that I believe, and also in some of the learning I've done in the program, social work program, addiction, period, is physically and emotionally a disease, both. It's not just physically, it's also emotionally too, so.
To what degree? That's the issue.
What?
I don't know if I'm an expert to answer that one.
Yeah, you asked Dr. Kalfas.
Yeah, Dr. Kalfas would be adorable.
20%
You need to write that question down for Dr. Kalfas next week, because he'll have an answer for you. Yes, sir.
I
Well,
think he says both.
One of the things that this class has helped me realize is that, you know, when somebody shoots up in Open Rhine, or when somebody shoots up in a back alley in Covington, that's not only their problem, but it's my problem as well.
Sure.
And, you know, we were talking before class, if you do the arithmetic, Scott County, Indiana's healthcare costs just shot up this winter, anywhere from 54 million to 88 million.
Ouch.
If you consider that, you know, an HIV case costs anywhere from $300,000 to $600,000 to treat, multiply that by all the, you know,
Yeah.
cases.
Could you imagine if that happened in northern Kentucky?
Uh,
As alarming rates. What it would impact our entire community, you're right, financially, and it would strain all of our resources.
The
Absolutely.
Kentucky Medicaid system will fall.
Oh, absolutely. We couldn't, yeah, I mean, it would be financially devastating, I think, to our entire community.
And the governor is still opposed to needle exchange, unless there's an epidemic, and by then it's too late.
What, in Kentucky?
In Indiana.
Oh, Indiana, yes. But Kentucky, no, I couldn't believe that. I feel so blessed that we actually got that through on House Bill 192 in Kentucky this last session, because everybody said if you keep it on there, it will fail. And it did, and that just goes to show that we have been doing some education and understanding to our legislators, because they got it.
With so many conservative people
Yeah.
in Kentucky, it's surprising,
Mhm.
you know, but based on there's an epidemic.
Well, and I think it comes down to having facts and understanding
Right.
and seeing the success of other needle exchange programs and what it's done for other states. That's helped us a lot as well. So we've learned from our partners as well from across the river in other states. Yes, ma'am.
So you said earlier that a lot of times people will come in, have an overdose, or will have had an overdose, come in, and then they get discharged right away. And obviously you guys provide them with resources, but what kind of resources are there if someone doesn't have great insurance? Like I know a lot of people just don't have good insurance,
Yeah.
unfortunately. And I know I've experienced it with my dad. He tried to go into treatment for alcoholism, and his insurance wouldn't cover it. So he couldn't, it was gonna be $3,000 out of pocket, he couldn't afford it, so he just didn't go. So what kind of resources are there for people suffering from a drug addiction, trying to get help if they don't have the insurance to cover it?
There are free beds available at certain facilities, so you have to know. Of course, there's a waiting list. I will tell you that my brother benefited from a free treatment bed because he didn't have a dime to his name either. And I refused to let my parents pay for it because they've already helped him once with the, not help him, but they did emotionally and financially help him to some extent. But I would not let him do the other because they're trying to retire, and I knew how much strain he'd already put on them financially. So, but he benefited. He had to wait for 3 months to get a treatment bed. But he got one. But I will tell you, one of the good things is, so when a patient comes in through the emergency room without the insurance, we are signing them up for Medicaid. So we are kind of closing that loop for them. We just got, there is facilities who take state Medicaid, but then again, they want that dual diagnosis. And until this past week, I didn't know how difficult that was going to be. What we are working on is, we have a resource finder, and it tells you. My problem is, and we try to get this data before, but it changes so much. Okay, who takes what insurance, how much, but it's so dependent on what your income is. And so for me to try to call a treatment facility and say, oh, how much is your bed? They're like, well, how much do you make? And it's so hard to try to pinpoint that. But we will try to work with people and try to find the best resource for them and to meet their needs financially and other. But it's a huge challenge for us. It took us 3 days to place a 20-something-year-old female last week. 3 full days. Between
the longer you wait, the higher the risk is of them just saying, forget it, and
Well,
falling back into the addiction.
she did use in between that time. We tried not to get her. We asked her. She actually, the one time didn't use, came back to the emergency room because she said, I'm going to use. We told her just come back. And we gave her some fluids and some medicine to help her get through some of the withdrawal.
But she was awesome because she wanted treatment and she was making phone calls and we were making phone calls. But to show you how difficult it is, she wanted it and had Medicaid, and it took us 3 days to find her bed. And that's because we diligently were calling every day on the hour, and she was calling. So it was like, and she was on every waiting list from Louisville. And Ohio was a challenge because of her Medicaid. So that, that's what we talked about today is we need our counterparts across the river and us here to accept each other's Medicaid because we don't have enough resources. They don't have enough and we don't have enough. But if we can combine them, we might be able to do a better job regionally. So we need to look at that. But that was a big challenge for us. And it is. And until we start assessing these patients and trying to figure out those things, we're not gonna know what all those barriers are, because I'll tell you, when we give them a stack of resource book that's this thick and say, here you go, good luck to you, go down the list, no bed, can't afford it, won't take women, or, I can't go here because of this. It's so rejecting that they just throw it aside and say, oh, we'll just go back to Houston. This is horrible. I mean, I want help and can't get it. So we have to do a better job with our system in our community, not to, if those people are coming to us begging us for help, I mean, we will do everything we can of our power. We actually made a couple phone calls with some people that we knew to say, okay, if anybody leaves, please put her on the top of your waiting list because she's ready to come in. Like, there might be, so Brighton Center has a waiting list. And what they'll do is they'll go down the list, and if you don't answer or you're not ready for treatment, they'll go to the next person and the next person. So they might go through 10 or 15 people before they find somebody who's ready to come in when they have a bed open. So if you have somebody, what I wanted the community to look at is, keep some beds readily available, open for when we have a crisis, that we can get somebody to a bed because they're ready. And, and so we're really looking at that as a community to try to do better at that. But it was straining on my staff. I mean, I was on vacation and called to follow up to see what had happened. But it took them 3 days, they told me. But you know what, kudos for them for staying on top of it and helping her. But it's a challenge for us, and it's going to continue to be a challenge.
I was just gonna ask you how many are still alive.
Do you want to take a short little break, or
Well,
you
I
want
was
me to
afraid
finish
that
up?
some people might need to stretch their legs. But I also know you need to get out of here. Just stand up and stretch their legs.
Yeah, you have to stretch for a minute. I'm probably only going to be done within the next 30 minutes if you guys want to wait for them for a break, if that's okay with you. Otherwise, I can take a break, so I'll let you guys.
Yeah, right.
I was just gonna say that, I visited, the center, and they had a 30-day recovery, facility. And it was private, $45,000 for the 30-day treatment.
Wow.
45.
So what are some behavioral signs of heroin and abuse and addiction include? This is what was so eye-opening for my parents. These are the behavioral signs that they didn't have, had no clue what to look for. So this was pretty eye-opening. I share this a lot when I speak out in the community to parents because I think it's very important. The nodding off, the substantial amount of time that they use increased sleeping. They have no drive, no motivation. Heroin is an opiate. It causes you to be drowsy. I mean, it gives you that intensive euphoric feeling and it helps with your pain, but it also causes a lot of sleepiness. You avoid eye contact, distant field vision. Why do you think you would avoid eye contact? Pupils, right? Absolutely, because they're tiny and small. Increased slurred speech, garbled speech, incoherent speech, worsening performance of schoolwork, or including expulsion or loss of jobs. I think that's important. When I was speaking to teachers, you kind of have an idea, what's going on with your students, and when they start slipping or something's going on, what's your reaction? You want to know what's going on at home, what other things you need to be looking for, and I think that's really important when there's starting to be a difference in performance. Loss of motivation and empathy towards future goals. They really don't care about next week or next month. I mean, you would have a conversation with your kid and all they can think about is, what they're going to be doing the next hour once you get done talking to them. They're not really looking towards the future. Withdrawal from family and friends instead of spending time with new friends or people with no natural ties. I think that was the hardest part for me. I've been doing this since 2012, been a nurse for 20 years, and my brother was addicted to heroin, and until he got arrested in June of 2012, we had no idea it was even affecting our own family. Pretty sad, right? Well, not really, because he would have to work or have some excuse he didn't feel good and not come to a family function. He would use Suboxone or misuse Suboxone instead of using heroin, so his pupils weren't small. He was, alert and oriented and doing fine because he was using that, so we wouldn't know that he was addicted or that he was going through some withdrawal when he was trying to get off the heroin. Repeatedly stealing, borrowing money from loved ones, or unexplained absence of valuables. One blessed thing is my brother never stole from my parents. He lived there for free. I wouldn't say he stole. He used them financially, but it wasn't. It was mainly just normal life stuff, not stealing or borrowing from them. But he was on that path. I think there was a divine intervention. He was one of the kids that, our law enforcement on that 471 bridge are very attuned to who goes over and comes right back within a short amount of time. And he was the one that got busted with a minor traffic violation coming back across that 471 bridge. Because they had to have been watching him and how many times, he's gone over there or come back over a period of time. So, I think that it would have led to this path, if he would not have gotten arrested, and it opened up everybody's eyes to it. That's the one reason why, I think when Dr. Engel chose me to start getting data, I had no clue. I know how it was affecting my healthcare professionals, how it was affecting my staff, how it was affecting our healthcare, but no idea that it was going to affect my own family. And I really believe that learning what I did helped us as a family survive, but not only that, my parents. Because if we were all blind to this and had no clue what was going on, they would have, it would have just been I don't know where we would be right now, to be honest with you. I commend you all. A lot of you guys have personal reasons for being here and taking this next step in your educational lives, and I think that's huge. And that's okay, because you're going to be better at your job and dealing with these clients because of your experience. And I really think that makes a big difference. I think when you've been affected by it, it really does share your passion differently and your understanding. And it really does make people stand up and notice a little bit differently. I'm going to switch PowerPoints. Well, one thing I didn't talk about is hostile behavior towards loved one, blaming them for their withdrawal or broken commitments. A lot of the behavioral changes, when I talk to parents, when your kids are hormonal, so when they're not hormonal and you have all these other changes, it's things to look out for. Are they hostile, just mean and angry about things? That could be part of them going through withdrawal. They're angry that they're even addicted. So a lot of those other behaviors you need to look at. So I'm going to switch PowerPoints real quick, because I just got back from vacation and I wasn't as organized, so I should have been.
Are these in the new module too? These PowerPoints?
It's not yet.
No, I'll send them to her when I get back.
great.
I'll send her to her in the morning.
Great.
So is that all right by in the morning?
Oh, that's
Okay.
fine.
And then-
I'll post them over the weekend.
Okay. So what I wanted, and I know that Jim Thaxton was here a couple weeks ago and talked about the Northern Kentucky Regional Plan and what we're doing as a community. But I kind of want you to let you know who all lives in Northern Kentucky that's here. All of you? So for you're Indiana, right? No? Where are you from?
Hamilton County.
Oh, okay. Well, that's all right too. I like Hamilton
I'm
County.
from Claremont.
Oh, okay. So, if you live in this community, I think it's important for you to know what we're doing at St. Elizabeth to help Jim and the Northern Kentucky response team for their community plan. Like I said, it's been some milestone changes for me. I think it's been pretty exciting, only because I feel like there's been some light bulbs that have gone off and some more eye-opening, and that's really come down to a lot of education and stuff that we've done. We know that we need to work on reducing the supply. The strategic plan is for law enforcement and dealers and the community watch. Where we fit in is patient education and provider education. And then you got your law enforcement and your legislatives. As far as establishing a regional and structure, we play an active role in the leadership team. We have several of our members of our healthcare organization on the Northern Kentucky Heroin Impact, and we submit data and we provide community education. We are advocating for bills. I've testified at the state level multiple times, and now following up recently with the House Bill 192, because not only did they pass the bill, now they want to follow up and see how we're being impacted by it and what we're doing in response to it. So that's been pretty exciting. We started a Narcan distribution kits. St. Elizabeth, along with Louisville, University of Louisville and the University of Kentucky, got some grant funding to distribute Narcan rescue kits to patients who come in through our emergency room as a heroin overdose. We have been doing this for the last a little over a month. We have some stipulations. They have to have somebody with them. We have to educate not only the user, but somebody with them in the family. And it's been good. We've already had a save from it, from a son who used it on his mother. Believe it or not, it was a teenage son who used the Narcan rescue kit on his mom. So the ER called me that used the kit and said, can we give her another one? And I said, absolutely. There's no penalties here. It's not 3 strikes, you're out. I don't care if you come in to get 3 Narcan kits from me because you overdosed 3 times in our emergency room. I don't care. We will give you 3 kits. So there's no penalty strikes there. We all are also helping our law enforcement distribute Narcan. We are working with Jason Merrick and the PAR team on some education and his harm reduction efforts. When House Bill 192 got passed, the Good Samaritan law was included where our law enforcement can use the Narcan rescue kits to help save lives. And we're slowly getting there. We have some good news is because we've had, I think, 2 law enforcement agencies already use the Narcan rescue kits to save lives. But what St. Elizabeth has offered to do is to give every law enforcement cruiser a Narcan rescue kit as a startup and then 3 refills. So we're committed to, because when House Bill 192 got passed, none of these law enforcement agencies budgeted for the Narcan, and they're just strained on resources just like the rest of the community is. So St. Elizabeth stepped up and said, we will help you with your efforts if you want to do the Narcan distribution. And I actually had one law enforcement agency that was kind of on the fence, and then when they had a save, now he wants a lot more kits delivered to his agency. So I'm excited about that because, what I keep saying over and over again is we can't put people in treatment if they're dead. They have to be alive for us to get them into treatment. And I don't care if you have to save them 5 times or you save them once. We have to continue these efforts. And I think that we're working really hard on doing that. We're also doing a lot of community education, which Bonnie talked about and I've talked about. And the other thing that we've done that I'm pretty excited about is we brought Betty Ford and Hazleton to Northern Kentucky. Who to learn from the best, right? This is their specialty. This is their wheelhouse. This is our evidence-based practice. These are the ones who are the best at doing what they do. Well, they developed a program and they piloted at their own facilities called the Core 12. And what it is, it's medical-assisted treatment along with the 12-step program. So, and it's tailored. So there's an abstinence piece, there's a medical-assisted piece, and then it all kind of tailors to a 12-step program. What I'm excited about is we didn't people thought when we were bringing Betty Ford and Hazleton to the community that we're putting like a brick and mortar building up, but we're not doing that. I think what we're doing is even better than a brick and mortar, because if you put it up a brick and mortar building, you're only going to be able to help this many people. But putting a community plan together out in the community called Core 12 with the Betty Ford and Hazleton evidence-based practice changes, we're going to be able to help a lot more people than if we were only going to be able to house them in a building. Because we're including our other community partners to learn about this and to take it forward to their agencies and try to implement and do the same kind of programming that we're going to be doing at St. Elizabeth. We're adopting it into our treatment plan, and we're trying to get our community partners to understand and give them the education to do the same thing. So we brought in them for toolkit trainings. We're going to have some more in the fall. That's really for our community. That's for you guys to come and learn a little bit more about the Core 12 and the 12-step program. And then we have some medical assisted training days, which we did our internal folks a couple weeks in late June. We're doing some of our community partners in late July. Those are for the people who are providing the services and all that, to understand that, to see if that model fits into their treatment programs and plans that they already have in place. It also gave us education to help Bonnie and her team out for schools, teachers, students, law enforcement. There's community education pieces for every piece of the pie, plus public service announcements and all kinds of stuff that we can adapt and use from. Because they've done it, they've lived it, and it's pretty neat. I was just talking to somebody in Frankfurt last week, and they mentioned that we were doing the Betty Ford, he didn't mention St. Elizabeth, which I got on him about, Dr. Bezold, is that who? Brenzold, yeah. Because he said, oh, you know, one thing that is we need to look at is this Core 12 program. And I'm like, I went over to him, I'm like, we're already looking at it. We already brought it to Kentucky. He goes, I know, I'm trying to get some funding to bring it to Lexington. I went, oh, really now? So pretty cool that they're really starting to branch it out, but they learned it, you know, we brought it to Northern Kentucky, and now our counterparts in the rest of the state are like, okay, what are you doing and how can we get our hands on it? So I invited them to come up and see what we're doing at the next toolkit training, because I think that'll be important, and hopefully they'll get their grant funding, will get approved, so they'll be able to start that through the state. So that's pretty exciting. I think we really are trying to take a different approach. You know, this is an addiction that we can't just sweep under the rug and not look at. We need to understand it. The treatment is so different than anything we've ever faced before. But I think putting resources in the community that'll allow us to help with this heroin addiction will allow us then to take other diseases and other addictions. You know, heroin is the drug of choice now. Who knows what it's going to be 4, 5, 6, 10 years from now? So we need to put things in our community that's sustainable, that allows us to add something now, and that we could be able to put any kind of drug in, and we're going to have a system that is full circle, full loop, that if you come to and present to any one of our agencies to say, I need help, we're going to know exactly where to put you. You know, and that's really our goal in our community. And I know Jim talked a lot about that with Northern Kentucky. Well, I appreciate your time and being here. I want to thank you. And if you have any questions, Bonnie knows how to get a hold of me. I'll send her my PowerPoint so you guys will all have that. Great discussions on Blackboard. I kind of miss, I shouldn't say I miss Blackboard, but I know I lived it too. And I tell you, the best learning that I had was through Blackboard. It really was. So I encourage you to. I mean, I was on an online program, so I had people from all over on our online program. But you really, when those discussions start happening on Blackboard, and not to give you a little plug, I tell you, those were the best. Those were things that you really got to hear. And some people don't maybe want to speak up, but maybe be, hey, what about this? Or, you know, I think those are great, rich discussions to have. And I want you to continue to do those, and hopefully, because I really feel like Bonnie said earlier, I mean, it is valuable to the learning, the Blackboard part is, because you really get to feedback and interact with each other. So, and I love that part of it when I was in school, so.